Hello, good afternoon. So today we have a very wonderful opportunity to talk about the heart failure, the interventions, and also related to some innovations approach. So we have some several distinguished guests on the next to me. So the next is left, Dr. John A. Spurtus, so from St. Luke Mid-American Heart Institute. And as the next one is the Dr. Jo Yang-yeon from the Seung-Yun-Gan University. And the last is Dr. Park Jin-ju from Seoul National University. Okay, how are you? How are you today?
Very well, thank you.
Very well, good.
Thank you.
So this morning we had a very exciting discussion sessions about their heart failure interventional approach with a lot of the new device and new innovations. So could you wrap up your the one you talked this morning?
So it was a terrific session, and we started with an overview of emerging therapies, both medical and devices for heart failure, with a focus on sort of the continuity of care, how we sort of think about evaluating and initiating treatments for patients, monitoring their response, and then up-titrating therapy. But the vast majority of the discussion was really on novel interventional approaches, including renal denervation, left ventricular venting, the opportunities to think about structural heart disease, especially with the exciting new data around MitraClips. And did I mention renal denervation already? And LVAD therapies that are starting here in Korea. So it was
also monitoring the pressure, pulmonary pressure monitoring.
So we discussed two alternative approaches. One is the very exciting work in pressure monitoring with the CardioMEMS device, and that is we're just getting familiarity with it, but the clinical trial may have even underestimated some of the real benefits over time during the open label as physicians got better and more confident in using the therapy. And then we also talked about systematically measuring patients' health status over time, their symptoms and function and quality of life, using the Kansas City Cardiomyopathy Questionnaire as a very low-cost alternative to monitoring patients. And it's probably better for periodic responses of the evaluation of new therapies when you don't have as invasive and detailed approach as monitoring the PA pressures with the CardioMEMS.
Okay, thank you. And Dr. Jo, could you also summarize the one you talked this morning about the LVAD system? Yeah.
Yes. So we had the opportunity to discuss about updates and outcomes of left ventricle assist device. We reviewed previous publication and registry reports, and we conclude that LVAD outcome in destination therapy patient 2-year survival was seems to be around 70%, and in younger group, generally BTT patients, 2-year survival reached to about 80%, which is very close to the transplant patients. And then in terms of updates of LVAD, we had so much exciting data recently with 3 randomized trial comparing HVAD and HeartMate-2 in DT patients, and comparing HeartMate-2 and HeartMate-3, most recent device. From that trial, HVAD was not inferior to the HeartMate-2 device in DT patients, so FDA approved use of HVAD in DT purpose. However, we found that the stroke rate significantly higher than HeartMate-2 in HVAD than HeartMate-2 patient. In the Momentum 3 trial, we found that newer generation pump, HeartMate-3, showed a significantly better in terms of complication and stroke, but the survival was still similar with HeartMate-2. So I also quickly showed our small data, 17 patients who had LVAD in our institution. So our 2-year survival was around 80%, so pretty much similar with US and Europe data.
Okay, thank you. Yeah, maybe Dr. Park, what was your, the impressions that you learned this morning? What was the most impressive one?
To summarize this morning, it was a great session, in my opinion. We had interventional cardiologists, thoracic surgeons, and heart failure specialists, all very had a great, inspiring talk today. For me, it was interesting that when you treat heart failure patients, we sometimes are confronted with the limit of the weapons we have. So I'm saying as a heart failure specialist, I'm very familiar with drugs, with pills, not with devices. And so my concern is that what if the patient does not improve with the weapons that I do have, the ACE inhibitors, beta blockers, etc. When can I get help from others? And today in this session, I know where I can ask for my help. The great help from the cardiac surgeons who can offer LVAD for the DDT or BTT. We also know that we can also use the RDN for the neurohumoral modulation. So if the patient is on optimal therapy, receives a full dose beta blocker, but still is still hypertensive, and still have a higher, let's say, I'm not sure whether they had a higher heart rate in this 2 cases we saw today morning. But if you have signs, if the patient has any signs, the symptoms of still elevated neurohumoral activation, we can also perform RDN. And I think the cases were so impressive, in my opinion. And the mitral clip, another issue. As a heart failure doctor, you know that some patients do develop this functional MR. And if the heart undergoes kind of remodeling process, and I think there's no point of return. If you cross this point, you cannot really get the patient back to the normal path with the drugs we have. Then we have to go back with the other option, and this is the exactly hemodynamic alteration. And one very good option is this mitral clip. We saw 2 remarkable study data today. One is positive, the other one is neutral. And we had great discussion that one study, we saw the differences, because I always wonder why the one was positive and the other neutral. And we had a great talk about the probable or possible causes for different outcome, and it was so great today.
So given the comment, your comment about the mitral clip, why don't you have some specific, more detailed, the discussion about it? So already, Dr. Bang mentioned that we have some 2 conflict, data results about the mitral clip. The one is very discouraging, so from the mitral FR study, and the other one is a very encouraging study from the COAPT trial. So what was, what is the critical difference between these 2 studies?
So that was a source of much discussion today, and Greg Stone articulated a lot of the conflict when he presented the results at the TCT, and basically, there are at least 3 domains where we think that there are real differences between the 2 studies. First is the patients in the COAPT study, which was positive, were really maximally treated with medical therapy and had remained very symptomatic. And so, to me, when you've exhausted the alternative option and you have something that's beneficial, it's easier to detect that difference. And I think it means that it's very important that we be very careful in selecting the patients for whom we're going to alter this wonderful therapy. And in particular, they had more MR in the COAPT study, and so we feel that that was more of the causative link of their poor outcomes, and so correcting that would be very beneficial. The second domain that was really impressive to me was that the success, the lower procedural complication rates and the less residual MR in COAPT was really substantially different than in the MITRA FR study, which also is a warning to us that we need to be sure that we can do the procedure well and safely. And the expertise of the people putting in the MitraClip and COAPT, I think was what resulted in the better long-term benefits of that. And as this therapy is disseminated more broadly, it's a difficult procedure. I mean, I don't do the procedure, but my impression is that it's quite challenging. And one of my colleagues, Adnan Shratwala, did a study in the US in a large registry to figure out where does the learning curve get better. I mean, how many cases does one have to do before they have very good procedural success without complications? And it's a long curve. It takes a lot of time. So we're going to have to think about how to properly proctor and ascertain the expertise of the interventionalists before they're doing a lot of these procedures. So both patient selection and procedural expertise are going to be very important. And, you know, I think that we were all very impressed with the COAPT results.
Yes,
and,
right.
I mean, to see something improve survival, markedly reduce hospitalizations, markedly elevate quality of life, that's a home run. And, you know, the challenge for us as we extend this therapy to our patients is to figure out what are the components that led to such a home run that we can make sure we disseminate broadly so that, you know, future patients can really benefit from this technology.
Okay, yeah, I totally agree with you. So maybe we have been a little reluctant to accept the MitraClip because it's not an easy procedure. So that's one of the
Yes.
reasons. However, now that we have some concrete data from the COAPT, I think that all the Korean doctors should try to get it. And also it's worthwhile to learn, even though it's a very difficult one.
So
Yeah.
I think so, and I think there's a lot of enthusiasm by
Yes,
interventional
right.
cardiologists. I mean, the speed with which TAVR took off
Yeah.
is really impressive, and I think we want to be humble that it's a challenging procedure, and that we really want to get great local experts in Korea to really master it themselves, and then train others to do it, perhaps at a slightly more measured pace than the speed with which the Korean interventionalists have adopted very complex angioplasty or TAVR procedures, just to make sure that we can do this very effectively and safely.
Yes, exactly.
And there were the complication rate in COAPT was about a third of that in the MITRA FR.
Yes,
And
right.
so that's a big difference. And so I think it really harkens to how important it is to really get the technical skills correct and to figure out how do we train the most doctors to do it the best in the most efficient way without people running ahead of their skill sets.
Yes, right. Good, thanks. So, Dr. Park, do we have any data about the drug that can reduce the mortality as much as the COAPT studies?
Currently, we do not have a drug that's as effective as COAPT, but we have to be very careful because you have another MitraClip versus drug trial. This is not the case. So the first drug that improved the mortality was enalapril. It was published in 1991 in SOLVE trial. At that time, the number needed to treat was, as far as I remember, is like 19 or 20. So you need to treat 20 patients to save one life.
Okay.
And it was a placebo. The comparison was a placebo. The last trial we have is a Paradigm AHF trial. We have a sacubitril valsartan. And in that trial, every patient was optimally treated. The beta blocker prescription rate is over 90%. All of them received RAS blocker, and about 45% received MRA. It's an optimally treated patient group. And in that patient group, patient who received sacubitril valsartan has a 20% less mortality as a relative risk. And the number needed to treat was like 19 as far as I remember. So if you compare Paradigm HF trial, which was actually the was surprising, the most surprising drug trial in heart failure in the last 5 or 10 years. We have a drug that is effective, and we're talking about NNT of 20, co-apt, optimally treated patient, very high risk patient. And we're talking about NNT of 5 or 6. And this is a remarkable outcome. But I said to you, we can't really make a direct comparison between mitraclip and drug. But still, if you look at the patient group, we have talking about EF function 3, 4, 2, 3, 4, 8 patient in the co-app trial. And we have a very severe functional MR, grade 3 plus or 4. And if you look at the data, patients who have those outcomes, they have much worse outcomes compared to those with a functional AMR. So co-app trial is, I think, one of the major breakthrough, in my opinion, because there's actually no trial which improved hemodynamic or alteration of the hemodynamic alteration and that led to beneficial outcome. So I want to have a little thought from you about the reduced LAP trial. So you can put a shunt between left intraarterial shunt to reduce the LA pressure. And this is an intervention regarding the hemodynamic point of view. Do you think, and we have the data until now shows that there is no benefit, survival benefit. Do you think did they have a wrong target with LAP pressure, or do you think it's a totally different thing?
So I is that to me?
Yeah.
So first of all, I would say that one big difference between coapt and the use of salcubitrol valsartan is that salcubitrol valsartan is applicable essentially to all patients with reduced ejection fraction, and they're going to be releasing the Paragon trial to look at preserved ejection fraction. Coapt is only applicable to those with severe MR, which is a much smaller subset. So from a population health level, the NNT, although larger with the drugs, can benefit a lot more people than a more restricted treatment of functional MR. And so from a public health perspective, I still think that the drug folks like you are going to have the biggest impact on saving lives, and only when you can't make them better and they still have tremendous MR would you be referring to your interventional colleagues to help you out because the drugs alone didn't work. It is a very interesting concept to do these this intraatrial shunting, and I think that it's intriguing and there are several technologies that are now in testing, and we definitely need a lot more data, I think, to be able to really understand both the potential benefit, but also the right patients. I mean, maybe it was part patient selection that led Mitra FR to not be successful. And, we have to realize we're always learning what patients benefit the most and which of our armamentarium of therapies are best for which patients. And so I'm intrigued with the intraatrial shunting, particularly in heart failure with preserved ejection fraction, because we don't have a lot of options for them. There is a lot of evidence, and we discussed it today, that perhaps better fluid monitoring with the PA pressure monitors like CardioMEMS can help us manage the HFpEF population. There are a number of drug trials, including not only salcubitrol valsartan, but all of the new SGLT2 inhibitors, which is a very interesting opportunity, and it's being tested both in diabetic and non-diabetic patients. And that will be a very interesting series of studies to come out over the next 3 to 5 years. And so I'm not as discouraged that the number needed to treat is higher with drugs than with devices, because frankly very few of our devices are as powerful as either the early partner data or the coapt data have suggested. And those patients were really sick and they would have very bad outcomes without an intervention to their structural heart disease. And so I think that's in the best light, and the drug trials are more in a real world population. And so it doesn't bother me that the number needed treats higher personally.
So talking about sick patient, now we have a sicker patient that are your patient, I think, who need LVAD support. We saw that you show a 3 randomized clinical trial showing there's also incremental improvement, but we still have a problem with infection, stroke, etc. Do you think there is a technical possibility to eliminate this risk, infection, stroke? Do you think one day we'll manage this, or is it something we can achieve with mechanical support?
Yeah, that is very important point. I think in terms of stroke, as I showed earlier, we are approaching there. We have decreased the rate of stroke by redesigning the pump for newer centrifugal device. So at 2 years, the stroke rate is less than 10% in such a sick patient. I guess even a usual non-LVAD heart failure patient, probably the stroke rate is considerable. So maybe very similar with general heart failure patient. So that's we are approaching. But in terms of infection, we still need to have a drive line through the skin for years at least. So I don't think we are there. So we still have a problem of infection and at some degree of stroke as well. So that is big challenge. And early readmission rate is really high. There are many reasons to get readmitted. Sometimes just a simple mistake from the patient or family, and some early complications such as a stroke and bleeding problem. Yeah. So in terms of bleeding, we still have to give at least one antiplatelet and warfarin. That's a standard of care. Those is also something not solved. But as you know, companies are working on to get rid of drive line.
That'll be a huge advance.
Yeah, try to make a device with better hematocompatibility. But in terms of bleeding, we cannot eliminate.
I have a practical question for you. Is the HeartMate 3, it seems like it's a lot harder and technically more challenging to insert than some of the alternatives. Is that true? I'm wondering why that isn't dominating the market, and yet it doesn't seem to be, given the lower stroke rate, which is a dreaded complication of. Are there technical issues that make it more difficult to use that particular device than the other ventricular support devices, the HeartMate 2 or the HVAD?
In terms of implant technique, I don't think there is a big difference between devices. HeartMate 2, because we have to make a pocket, there's little bit of increase of technical difficulty. But between HVAD and HeartMate 3, both are centrifugal device and smaller than HeartMate 2. No need to make a pocket. So I would say very similar. But HeartMate 3, probably you have seen in the booth or from your patient CT scan or X-ray, the radius, diameter of HeartMate 3 and HVAD is quite similar. But HeartMate 3 is much thicker than HVAD. So very difficult to put it in through the thoracotomy because it's depth. So that is it. So your question is why it's not dominating?
Yes.
So I will ask you first, what is dominating device in your hospital bed?
Well, we have some heart failure doctors who are very bullish about the HeartMate 3, and the surgeons have been a little resistant, but they're putting a lot of pressure on them to change. So I think we're seeing a shift in our hospital. We live in an unusual environment in Kansas City. We have tremendous access to hearts. So traditionally we've done a lot more transplants than left ventricular assist devices, but in America they're changing the prioritization, and so we're anticipating having to share our hearts with Chicago and Dallas and St. Louis, and so with the larger area of having to share hearts with, we'll probably have to go to more ventricular assist devices, and I presume, given the bias of our transplant advanced heart failure doctors, we'll be shifting more to the HeartMate 3 because of the stroke rates.
Yeah, definitely. So why HeartMate 3 is not dominating yet is, I think number one is still in many countries still under trial. HeartMate 3, HeartMate 2 and HVAD already passed DT, BTT trials, and then they are actively using already. So that may be one of the reasons. And then all the heart cell facility and training have to be changed from this device and that device. So that is another burden to your team. So, and third is I have heard the production problem because it's something new, and then CEO is still watching the market, which way this will go, how much I have to make more HeartMate 3. So, still early stage of HeartMate 3, I guess.
Dr. Zhu, may I have some very basic question? Because I haven't involved in any, the heart transplantation and LVAD and so on. So this might be there's some basic question. Where should draw line between the heart transplantations and LVAD?
Okay.
Yeah. This is my basic
very
question.
important. Not basic, very important. So I always speak to my patients. Once you have transplant, you never had VAD, right? Yeah. Once you have heart, and heart may fail because of rejection, but heart is small, and rejection cannot be like a DCMP. It doesn't change like that. So you are not going to have a VAD later. Once you have VAD, you can live with VAD, or you can go to transplant whenever you want, or whenever you have complication. So that is a very important point. In terms of BTT and DT, because now the VAD is covered by our insurance system, I think we should be more keen to put a VAD to save our organ, and then give this valuable organ to better recipients at right time. So we should change.
Okay, if I may comment on that, is that the clear choice is heart transplant, in my opinion. The data of the patient survival of a heart transplant is much better than the LVAD patient. LVAD is progressing. The survival of a heart transplant patient does not improve recently, because I think we kind of reached the maximum care with the drugs we have for the heart transplantation. Heart transplant has a very good outcomes. So after 3 years, you're going to not be confronted with cancer, graft allovasculopathy, and you may develop other complications. But the long-term survival is still very good. So if you have the option, if the patient can choose between heart transplant and VAD, I really recommend my patient to go to have the heart transplant without doubt. But the problem is the organ shortage. So how long are you going to wait? How long do you have to wait? Are you going to survive the waiting period? And in that case, then we'll have to go there where we do not have a shortage, and this is the VAD. Technology this has been developing. And I think there's what I asked you before, is really progressing. We're going to have a lower stroke risk in the near future, I think. Maybe we're going to have a new drugs that can reduce the stroke risk. They can also reduce the bleeding risk. In that case, that may be the option, but currently I will go with the heart transplant.
Okay, thank you. The time's already up, so Dr. Spector, would you please summarize the key point of today's discussion? So we have only several minutes.
Well, I think as you can tell from the conversation today, it was a very exciting presentation. And what I think is, what I took away from this is that we really are sitting at the dawn of a whole new era of heart failure care. From drugs to devices, it's getting increasingly complicated, but increasingly hopeful given the myriad of options and really understanding what's causing the patient's heart failure to be worse and figuring out what therapies can I direct directly to those causes so we can maximize their survival and their quality of life is something that we're all going to have to learn a lot about over the next few years, so we really tailor treatment to risk and to benefit and really wisely use the very expensive technologies that are now coming our way to really improve the care and outcomes of our patients.
Okay, thank you. So we had a very wonderful discussion. So we may have to wrap up this session here. Okay, thank you everybody for participating.
Thank you so much.
Thank you. Thank you so
Thank
much.
you so much.
Yeah.
Really appreciate it.